Hello folks, this is John Adamson, the Rehab Documentation Guru, and today we're going to look at a speech therapy swallow treatment example and just wanted to look at whether or not this is going to constitute skill for very long. And some of the same principles I'm going to talk about today are going to apply to PTs and OTs as well. So just because this is a speech therapy example, PT and OT staff don't think that you don't have anything you can learn from this example. Let's look at this skilled statement, and this is obviously a patient with dysphagia, and it starts off by saying targeted swallow function by continued patient education and training regarding safe swallow guidelines, including slow rate, small bites, alternating liquids and solids. One of the things that was noted in this documentation was that the patient was the one that was targeted for education, not the caregiver. And the fact that this patient, and my OTs and some of my speech therapy followers will understand the Allen cognitive level assessment, but the patient scored a 3.4 in the Allen scale, which puts the patient squarely in the middle of mid-stage dementia. And first of all, I just want to talk about the fact that this patient is trainable, but there's a problem. These patients are going to require considerable practice over time. In fact, mid-stage dementia patients may take a few weeks to get a new activity. This is multiple types of steps to the swallow function, and because the patient's mid-stage, it may not be possible for the patient to remember all of these guidelines consistently, safely, and effectively to perform a swallow function. So the next question is, could somebody else learn to do this stuff? And excuse me, a non-skilled person. But I want to talk about some of the issues related to this documentation. This is a progress report. It's designed to justify 10 treatment visits. And you'll note that the focus was, first of all, was targeted swallow function. And that's good. We want to see action word, which the word targeted does relate to an action. Sorry, folks, I can get the words out. And what we don't have, though, is really what the target was. There's a reason to do slow rate, small bites, alternating liquids and solids, but we don't see what the speech therapist was trying to address. There's underlying impairments behind the need of that, and so not really sure what all of the skill was. There is definitely some skill here, but notice the next the next word, by continued. Anytime you use the word continued, you're giving what's called repetitive care, which Medicare is going to say, no, we don't pay for that. So try to avoid using that term. Your care as a therapist should always be evolving and changing over time. So this is not a good example of the use of skill. But let's look at what they continue to do. Patient education and training. Now, we already talked about the fact that this patient is trainable, but they're going to take a long time to learn this activity. And that the next question should be, are we training the right person? And given the fact that a speech therapist and OT should be fairly expert in the area of cognition, they would know through their assessment whether the patient is trainable and to what complexity of training the patient's capable. And in this case, this looks like a set of skills that you and I, with a normal cognition, should easily get. But a patient in mid-stage dementia, it's going to be very challenging for them to learn this 100% safely and effectively. And 100% on swallow function is really ideal, because all it takes is one bad swallow, and you've got a really bad event occurring. So this is definitely going to be something I want the patient to have 100%, and they're not going to get it based on where they're at. Now look at the things that the therapist taught. Slow rate. Now think about this. A non-skilled person would not know what a slow rate means, but there are ways to objectify this, and so the speech therapist should be seeking to objectify, like, what does slow rate mean? Does it mean so many chewings, mastications of that food? Does it mean a certain time period between bites? Can we objectify this? And folks, if you've heard me talk before, you know objectification of everything's super important. So what does slow rate mean for this particular patient? Can we objectify it? Small bites, what does that mean? And sometimes speech therapists will talk about, patients able to take a quarter teaspoon, half teaspoon, full teaspoon. So let's objectify that small bite. Let's talk about what that actually means. But alternating liquids and solids, that's purely binary. I mean, that's every other is a swallow of solids, every other is a swallow of liquids. That's not hard. So think about this. We can teach a non-therapist who has an intact mind to gauge the patient's rate of swallow according to some objective standard we set. Like, for example, we're going to tell the caregiver you can only allow the patient to have a bite every 30 seconds. Or you can only let them have a bite after 20 chews, or whatever it might be. Small bites, again, we can objectify it. We can say, okay, you can fill this teaspoon, but don't overflow it for every bite, or it's going to be half this teaspoon for every bite. So we can objectify that. And then, of course, alternating liquids and solids is very simple. And in fact, if we were training a non-skilled person to do this with the patient, which hopefully over time, if the caregiver is constantly cueing the patient to do it this way, maybe the patient will, even at mid-stage dementia, through rote practice, start to develop the habit of doing slow rate, small bites, alternating liquids and solids. But it wouldn't necessarily take us working with the patient every single time. And Medicare is going to expect that a person with intact cognition should learn this within a very few minutes. And in fact, most of your CPT codes and treatment that you do for training, Medicare will expect 2 to 4 visits total. So this is not going to constitute skill for a very long time. We'll expect this portion of the intervention at least to be done within a very brief time, turned over to a caregiver who then should be able to safely and effectively continue working with the patient on this. Anyway, I hope you found this helpful. Again, this is John Adamson, the Rehab Documentation Guru. If you like this video and my other video content, please like and subscribe. Please tell your therapy friends about this channel. The more hits to this channel, the more it has the potential to benefit me in the future. And please always remember, you can always leave a comment and ask for future video content that I would love to cover for you. Take care and have a great day.